Good day, dear great surgeons. Missed you all a lot, and today we're gonna talk about very important chapter in MRCS and in your life. There is no life without the children. The children are the privilege and the happiness of the world. They are the true pure soul of our world, and it's very important in our exam, in our life, and take care. The pediatric chapter is already overlapping with every chapter in MRCS, starting from the anatomy, embryology, orthopedics, trauma, endocrine, GIT, hepatobiliary, preoperative, postoperative, almost all the MRCS. So it's very important, and you might be surprised that the whole exam might be all about trauma, orthopedics, and pediatrics. So have your favorite drink and let's crack this lovely chapter together. Together we can. We will start with the sporadic congenital anomalies that are confined to the pediatric chapter, and together we can crack them together, like the Periatrisia and cleft lip and cleft palate, as well as the bronchogenic cyst, the choledochal cyst, congenital heart disease. All of those are included within the pediatric chapter and very important in the exam. So let's crack them together. And by the way, even the urological anomalies like the hypospadias is important. And by the way, the very most important topic in the exam will be the bilious vomiting in neonates. The bilious vomiting differential must be in your mind. So keep in mind what is the type of the vomit and what age did the patient vomit. This is the key to this question in the exam and frequently asked. And we will get through this point together during our revision. So get ready and have your favorite drink. Let's start with the Periatrisia. It's very common to find Periatrisia? No. It's 1 in every 17,000 to be affected by Periatrisia. So it's not that common. But with large population, it will be common. 1 in every 17,000 is very common, large population. But it's still, the uncommon is not uncommon. So, the biliary tree lumen will be obliterated by inflammatory cholangiopathy and causes progressive liver damage, and the clinical feature of the baby will be within the first few weeks of life. There is no family history of liver disease, by the way, and there will be a jaundice baby for more than 14 days. We all know that in less than 14 days, and the jaundice that start from the second day will be unconjugated, and there is no fear from this jaundice. It's physiological jaundice. But here, if the jaundice persisted for more than 14 days or even 21 days in preterm infant, this is considered a pathological jaundice. You have to search for the cause. So, when we have an infant in the first few weeks of life with no family history of liver disease, with jaundice for more than 14 days in a term infant or more than 21 days in a preterm infant, with a pale stool, yellow urine, colorless in babies, by the way, associated with cardiac malformation and polyspirenia and situs inversus, this must come in your mind. This patient, this pediatric, this child will be biliary atresia child, and you have to search for the cause. What investigation for this patient? Of course, do the bilirubin direct and indirect. You will find that the conjugated bilirubin will be prolonged physiological jaundice or breast milk jaundice will cause a raise in the unconjugated bilirubin, while the conjugated bilirubin, when it's rise, is pathological. The physiological jaundice will it's all about the unconjugated, the indirect one. Do ultrasound of the liver to exclude any extrahepatic causes in periatresia infant. There may have a tiny or visible gallbladder. And by the way, here comes the hepatoimmunodiacetic acid radionuclide scan, the HIDA scan. This is the key for our child. So, from all of these talk about the periatresia, there is no pathological jaundice for more than 14 days in a term infant or more than 21 days in preterm infant. The key to diagnose the biliary atresia will be the HIDA scan. The management will be early recognition. Your diagnosis will prevent the liver transplantation. Give the patient nutritional support. Do for the patient Kasai procedure as early as possible to prevent a liver transplantation. Your diagnosis in itself is a management for the patient. So if Kasai procedure fails or very late due to late diagnosis, a liver transplantation becomes the only hope for this patient. Take care. So, biliary atresia usually present with obstructive jaundice, and Kasai procedure is best performed in the very first 8 weeks of life. If Kasai procedure is successful, most patients will not require liver transplantation, while in 45% of patients post Kasai procedure will require transplantation. However, overall, the survival following Kasai operation is 80%, so it's worth it, totally worth it. So go for it and diagnose your patient. So, clinically speaking, when you find a baby, about 8-year-old baby brought to your clinic with history of 18 days of jaundice, and the mother is breastfeeding. He was a full-term baby, by the way. There is no family history of liver disease. What is the appropriate next step? Take care. Next step, we are not talking about you are diagnosing the patient already atresia. Go step by step. The very next step is to ask for conjugated bilirubin measurement. You are feeling of is this a pathological cause or a physiological cause. We all agree that the jaundice in term infant more than 14 days is mostly pathological, and in more than 21 days in a preterm will be pathological. We have here 18 days jaundice, so in a term baby, so it's mostly pathological. It's more than 14 days. So what is our next step? It will be measuring the conjugated bilirubin. After measuring the conjugated bilirubin checkup, you can suspect either it's a physiological or pathological according to its number, and if it's biliary atresia, you can go for ultrasound and hide scan. So take care, because if physiological jaundice, you will find that the unconjugated bilirubin will be raised, and the isotope scanning may be used in the diagnosis, but a definite diagnosis is normally made during a laparotomy. So always go step by step. Now let's have some glimpse over the bilious vomiting causes in neonates. The key to know the cause of the bilious vomiting in the neonates is when did it happen. Was this Adudenal Atresia, malrotation with volvulus, juvenile Atresia, or meconium ileus, or necrotizing enterocolitis? The age of presentation is the key. So let's take the timeline. If it's within hours after birth, suspect Adudenal Atresia. Take care, it's not biliary atresia. Biliary atresia about the biliary tree. We are talking about the duodenum. Duodenal atresia. It will be a vomiting within few hours of birth. While if we have within the 24 to 48 hours of life with abdominal distension and bilious vomiting, this might be a meconium ileus suspected, especially if the patient didn't pass stool. And if within 24 hours of birth, it might be either juvenile atresia as well, and the patient will not pass in stool. And if the patient presented within the first week, it might be malrotation with volvulus, and it will be volvulus with compromised circulation that might result in peritoneal sign and hemodynamic instability. While usually the second week of life in a preterm infant, it will be necrotizing enterocolitis. So again, the most common causes for vomiting or intestinal obstruction with bilious vomiting will be duodenal atresia within the very few hours after birth. The infant is not spitting on you when he vomiting. He doesn't know you to spit on you. He is a good, well-mannered baby. This is due to the duodenal atresia, so take care. It's not spitting, it's vomiting. It's a duodenal atresia within few hours after birth. While if the patient was a preterm within the 2 weeks after birth and he is born premature, take care. This might be necrotizing enterocolitis. While if the patient in the first week after birth, presented with compromised circulation, might result in peritoneal sign and hemodynamic instability, its malrotation with volvulus until proven otherwise. While if the patient didn't pass meconium within the very first 2 days and the abdomen is distended, of course he will vomit. There is nothing to pass below, he will pass above. That's why the meconium ileus will cause him the presentation with abdominal distension and pediatric vomiting within the very 2 days of life. And to sum up our diagnosis and our treatment, the duodenal atresia will be managed by duodenostomy. Again, duodenostomy. While the malrotation and volvulus will be managed by LADS procedure. It's emergency. The necrotizing enterocolitis will be a conservative treatment. There is no laparotomy. The laparotomy and resection in case of perforation, unfortunately. So take care. Duodenal atresia, duodenostomy. Malrotation with volvulus will be LADS procedure. Meconium ileus, you can try a surgical decompression, or serosal damage might require segmental resection, or the necrotizing enterocolitis. No, here we stand. There is no surgical intervention for necrotizing enterocolitis unless the patient got perforation. Take care. Let's apply the presentation of a necrotizing enterocolitis case. You all know a male patient who came to you born prematurely at 26 weeks gestation by emergency C-section. Following the birth, he developed respiratory distress syndrome and was ventilated. He begins to improve 12 days after his birth. Then he becomes unwell again and develops abdominal distension and passes bloody stool and vomits a small quantity of bile-stained vomit. Of course, this is enterocolitis. This is necrotizing enterocolitis, and the X-ray will show a dilated bowel loop and pneumatosis, intestinal pneumatosis. This is due to the necrotizing enterocolitis. The only way to manage this patient will be conservative and supportive for non-perforated cases, and the laparotomy and resection is only reserved for a perforated ongoing clinical deterioration. Take care. And necrotizing enterocolitis often has a delayed presentation and affect infant with typical pass bloody stool and show intestinal wall air. This is called a pneumatosis. Pneumo means air. Pneumatosis intestinal. So now you can ask yourself, how would an intestinal rotation can occur, or what is the presentation? It will be a male infant with spontaneous vaginal delivery. It's not a preterm baby at 39 weeks of gestation, and he is well after the birth, unlike the necrotizing enterocolitis, which was a preterm baby and with emergency situation to be born. So here in intestinal malrotation, the scenario will be regarding a vaginal delivery patient or whatever spontaneous delivery at a full term and established on bottle feeding and discharged home. His parents are concerned because he subsequently became unwell and vomits a large quantity of bile-stained vomiting approximately 2 days after discharge. The question will stay 2 days after discharge to exclude, yes, he will exclude the duodenal atresia, which will be within hours. So now it's not a duodenal atresia. So what can cause a full-term baby to be distended and cause a bilious vomiting? Of course, this is intestinal malrotation until proven otherwise. So on examination, he looks ill and the abdomen is soft and it's not distended, by the way. This is intestinal malrotation. So take care. If any child vomit for congenital hypertrophic pyloric stenosis, by the way, can occur, take care. If the patient gone unwell, this is the key to you to investigate. If the patient is unwell, don't trouble the trouble until the trouble troubles you. In intestinal malrotation with volvulus, the patient will typically compromise the vascularity of the luminal patency of the gut, and this will cause a bilious vomiting, and the vascular insufficiency will produce a clinical picture of illness at odds with the lack of overt abdominal sign. The abdomen will be not distended at all. and the delay of the diagnosis and surgery will result in established necrosis and perforation and peritonitis. So, never underestimate the patient mother complaint. Always believe the mother when she tells you that the child is not well. Again, another scenario for midgut volvulus, a 1 week-old baby presenting with profuse bilious vomiting and a tender abdomen. There is no palpable mass. What could this be? Take care. Midgut volvulus must be excluded because malrotation with volvulus is usually present in the very first week of life, as we all agreed, but may occur at any age, and the vomiting is bile stained. An urgent periam meal will diagnose the malrotation. If volvulus goes unrecognized, the entire midgut, we all agreed that it will become ischemic. Take care. Save this child life. So let's agree that time equal bowel. You can save this patient life, dignity and lifestyle for his long life by diagnosis this patient. I agree with you, it might be a vague scenario, but medicine is incidence. What can make a baby to vomit a bile-stained vomiting? There is no passage below that he all his bile gone with his vomit because there is nothing passed below in his very first week of life. It's a serious event. It's not his food. It's not he is having hypertrophic pyloric stenosis or something. No, take care. Think, what could this be? Let's now trick you about a very long scenario. A very long scenario about a female infant who was born by cesarean section at 38 weeks of gestation for a fetal distress. The attending pediatrician noticed that she has a single palmar crease. He is taking you towards the mongoloid slanting eyes and down and trisomy 21. Yes. Soon after the birth, the mother tries to feed the child who has projectile vomiting about 10 minutes after feeding. This is within the very first day. On examination, she has a soft, non-distended abdomen. What can this be? Of course, she is not spitting over the pediatrician. This poor little child infant, she has Adudenal Atresia. A proximally sited atresia will produce a high volume vomit which may be or may not be a bile stain. So don't give your mind is it bile stained or not within the very first day. We are thinking it's Adudenal Atresia or not. In the very first hours of life, after the very first feeding, it will be duodenal atresia. Abdominal distension is characteristically will be absent with duodenal atresia because there is nothing passing below to make her distended. There is nothing passing to the flora to make the child distended. So, the under-resuscitated children may be a little dehydrated that they are seldom severely ill. And the presence of trisomy 21 with the palmar and eye sign increase the likelihood of duodenal atresia. And a very common recall question to ask you about the association of the duodenal atresia with the trisomy 21 Down syndrome. Keep in mind. So yes, he guided you with the trisomy 21. He confused you with a long scenario, but the only key is the timing of the vomiting within the very first hour and the very first feeding in her life. She had a projectile vomiting. So to sum up again, the duodenal atresia will be presenting within the few hours after birth, showing the X-ray double bubble sign, and the counter study may confirm your diagnosis, and the treatment will be duodenostomy. The malrotation on contrast with the volvulus, it can come with the volvulus or will not. It's usually by incomplete rotation during the embryogenesis and usually will be presenting within the very first week of life. And by the way, it might come hemodynamically instability with the projectile bilious vomiting. Take care, and the abdomen might not be distended. And the only treatment will be LADS procedure. And what will you do for diagnosis? You will do upper GI contrast study that will show the DJ flexure is more medially placed, and the ultrasound may show abnormal orientation of superior mesenteric artery or superior mesenteric vein. While the meconium ileus will typically be presenting within the very first 2 days and the baby didn't pass stool. Think what can cause this meconium ileus. Is it Hirschsprung or either or whatever? The abdomen will be distended, and by the fingering of the child you will find the gosh, this is Hirschsprung. If it's meconium ileus, you will find the air level on the x-ray and sweat test to confirm is it cystic fibrosis or not. And the treatment will be surgical decompression, or even serosal damage may require segmental resection. And necrotizing enterocolitis, when will it present? Yes, in a preterm baby. This is your key in the exam. Usually within the very first 2 weeks of life, the baby will come deteriorated, passing bloody stool with a preterm history. So this is necrotizing enterocolitis until proven otherwise. The mainstay treatment will be conservative and supportive for only non-perforated cases, but if perforated, go for laparotomy, resection of the perforation, and do whatever it takes to save this baby. Take care. So let's confuse you with a very famous rectal question about a newborn baby presenting with mild abdominal distension, bilious vomiting, failure to pass meconium after 24 hours. He didn't pass meconium after 24 hours. Again, he didn't pass meconium after 24 hours. In the long scenario, this is only key to answer the question. He will give you a very long scenario and tell you that he did a plain x-ray revealing dilated loops and bowel filled with air fluid level and barium enema demonstrating a segmental of colon with a conical appearance. Don't confuse you. Didn't pass meconium after 24 hours. It's meconium ileus. It's what is caused by Hirschsprung disease until proving otherwise. Hirschsprung disease occurring in 1 every 5,000 life. It's very common to be noticed in life. 5,000 isn't that rare. It's also called congenital megacolon or congenital intestinal agangliosis. It's due to the absence of the ganglion cell in the neural plexus of the intestinal wall. Again, it's due to absence. There is no ganglion cell within the neural plexus of the intestinal wall. And the Hirschsprung disease is more common in boys. We poor boys take whatever it takes to save the girls from the Hirschsprung. We take the Hirschsprung instead of the girls. The delayed passage of meconium, together with distension of the abdomen following feeds and bilious vomiting, of course, this is clinical feature for Hirschsprung disease, and the plain X-ray will demonstrate dilated bowel loop and the bowel filled with air fluid level, and barium enema will reveal that the affected part of the bowel have a conical appearance. This is due to the dilatation of the proximal ganglionic colon and the failure of the distal aganglionic part to distend. So the ganglionic part, the normal part, will be dilated. The abnormal part will be collapsed, conical collapsed, can't distend. And a biopsy of the affected part and anorectal manometric study may be needed to confirm the diagnosis, but it's clinical diagnosis, by the way. And you will find, by inserting the mother finger or your finger within the anal cavity of this poor child and removing it, you will find a gush of stool out of this anus. This is Hirschsprung disease. How would you treat a Hirschsprung disease? Of course, you answer correctly regarding the Hirschsprung disease. It's treated by Duhamel, Swenson, or Swavey. The very famous is the Swenson's pull-through operation. Take care. I love who brought up the achalasia of the cardia. Exactly. The achalasia of the cardia and the meconium ileus of the Hirschsprung must be studied together because it's all about the innervation and dilatation. And yes, the constricted part in the Hirschsprung is the diseased part, while in achalasia you will find the diseased part is the dilated part. Isn't medicine amazing? Go for it. Thank you, Dr. Sayeda. You are such a great surgeon. So again, to make it clear, the achalasia of the cardia, you will find a dilated esophagus which containing a few ganglion cells. But in contrast, the Hirschsprung, where you have a dilated colon which have a normal ganglion, but the constricted part which has a no ganglion segment. Aganglionic segment will be the diseased part, while the achalasia of the cardia will be dilated, containing fewer ganglion cells. So in the esophagus, the dilated have no ganglions, and this is the diseased part. While in Hirschsprung, the colon will be having no ganglion and will be constricted, while the dilated one having the normal ganglion. Amazing medicine. These great surgeons, just as important as the other topics in the pediatric surgery, the gastrointestinal disorder, you have noticed by now, they are very important. So you have to be familiar with the pyloric stenosis, congenital hypertrophic pyloric stenosis, acute appendicitis, mesenteric adenitis, intussusception, malrotation, Hirschsprung, esophageal atresia, meconium ileus, biliary atresia, and even necrotizing enterocolitis. All of those you have to be aware of. So we all now know the necrotizing enterocolitis, the meconium ileus, and discuss the Adudenal Atresia. So let's be familiar with the congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis is more common in male than female. It's about 5 to 10% in the family history in the parents, as well as it will present with projectile non-bile stain vomiting. This is very critical, crucial element, because all of the vomit will be within the content of the stomach, not beyond the pyloric stenosis. We all know that this pylorus is the cardiac and the pyloric sphincter of the stomach. The cardiac is more near to the esophagus, and the pyloric sphincter, which is differentiating and the gate towards the duodenum. So when we have congenital hypertrophic pyloric stenosis, how come that the bile come from the ampulla of water and jump up towards this stenosis? It can't go through it. That's why it's not bile stain, and there will be vomiting at the 4th to 6th week of life. So remember the Adudenal Atresia, it was the very first feeding event the baby have vomited. We agreed it's not a spitting. He is a well-mannered, cute, angelic baby. So it's not spitting at all. He is behaving. This is due to duodenal atresia at the very first moment of feeding. While in the 4th or 6th weeks, please consider, is it congenital hypertrophic pyloric stenosis or not? It will be diagnosed by ultrasound. You can feel by examination somehow an olive-like mass in the abdomen, and of course the treatment will be Ramstad pyloromyotomy. This is the pyloric stenosis. Now let's move on to the acute appendicitis and mesenteric adenitis. We all know that acute appendicitis is very common, but it's less common below the age of 3 years old. It's very rare in the extreme of ages. In the very low age, think of other causes of acute abdomen. But keep it in mind, the rare is not rare after all, but medicine is incidence. So in acute appendicitis, it's very rare in the extreme of ages, so it's uncommon under the age of 3 and uncommon above the age of 50. Above the age of 50, please consider the right iliac fossa pain like a cancer until proven otherwise, and do the whole full workup for this patient. If you are suspecting the appendicitis, you can go with the alveolar score. And by the way, there is no appendicitis without anorexia. If the patient is willing to eat, I doubt this is appendicitis. If you have done an ultrasound with a professional clinical dependent ultrasonographist, you will find somehow some lymph node. This is not appendicitis. It might be mesenteric adenitis. It will present with a picture resembling acute appendicitis with central abdominal pain, and you will find that there is a conservative treatment will give a chance for this patient with a mesenteric adenitis. With the ultrasound, it will be showing lymph nodes. We all know the intussusception, and we talked about the telescoping of the bowel, either the ileoileal or the ileocolic, and if ileocolic, most probably at the ileocecal valve. we all know the malrotation, and you have to treat it and suspect it early with the LADS operation, the Hirschsprung disease, as well with the Swanson operation and SWAVI. The esophageal atresia, keep it in mind because associated with tracheoesophageal fistula and polyhydramnios. You have to suspect Vactral, and it can cause cyanotic episodes. This is the esophageal atresia, keep it in mind. The meconium ileus and the Hirschsprung are part of each other. The meconium ileus, you have to do cystic fibrosis, and the x-ray will not show a fluid level as the meconium is viscid. Take care. And we all know that the biliary atresia, and agreed that it's more than 14 days of jaundice, and necrotizing enterocolitis will be managed conservatively. You have to know that necrotizing enterocolitis and this blood stool with necrotizing enterocolitis in a preterm baby is conservative management unless, unfortunately, the baby got perforated. Hope those have summed up the gastrointestinal disorders. Many have been asking me, how would the esophageal atresia scenario be coming in the exam? It's very irritating and we are afraid. Don't be afraid of any scenario. It will give you a key within the exam. Let's have those scenarios. A 3-day-old baby presenting with recurrent episodes of choking and cyanotic episodes. There is a history of polyhydramnios, so he is guiding you toward the esophageal atresia here. And by the way, the diagnosis will be confirmed when the nasogastric tube fails to reach the stomach. You can see it by the x-ray, or you can feel there is a resistance while trying to insert the tube, or it will roll up over itself and come back to you. This is esophageal atresia. Another scenario will be a 3-day-old baby is developing increased problem with feeding. On examination, she has a pansystolic murmur on her forearms, have not developed properly. So he is taking you to think of the Vactral. So this child has a Vactral, which is combination vertebral, anorectal, cardiac, tracheoesophageal, even renal and radial limb anomalies. Half of the babies with the esophageal atresia will be having a Vactral. So this choking and this cyanosis and this pansystolic murmur along with the forearm will most probably be with esophageal atresia. See? How about the mesenteric adenitis? A 2-year-old child is central abdomen and has a recent upper respiratory tract infection. This mesenteric adenitis, which complicates the upper respiratory tract infection and the clinical exclusion of appendicitis, can be difficult and can be confirmed with ultrasound and follow-up. So according to the level of the esophageal atresia and the tracheoesophageal fistula, it might be with each other or each one alone. The baby won't vomit, but he will be rather stressed. This might be due to cardiac anomaly or esophageal atresia. They are with each other. It's a Vactral syndrome, so keep it in mind whenever there is congenital anomaly or polyhydramnios syncopate. But if we have a typical scenario for Adudenal Atresia, it will be a patient with Down syndrome with ultrasound showing double bubble deformity in x-ray and ultrasound, as well as the baby will vomit from the very first bottle feeding or breast milk feeding, because the majority of the abnormalities occur distal to the ampulla of water, so the vomiting will be bile stained. But the patient with the esophageal atresia will be polyhydramnios with Vactral syndrome, and it will be distressing for the patient. While the pyloric stenosis, take care. In the pyloric stenosis patient, the typical scenario for the pyloric stenosis, which will require a Mishtat pyloromyotomy, it will be about a baby who is having projectile vomiting after the feeds. And by the way, it will take non-bilious vomiting, because we agree that it's at the pylorus. So hope this differentiates the esophageal atresia from the pyloric stenosis and duodenal atresia. By the way, don't confuse the Hirschsprung disease with the meconium ileus. Hirschsprung disease may be a result of the meconium ileus, but when we talk about meconium ileus, we are talking about distal bowel, small bowel obstruction secondary to abnormal bulky viscid meconium. But in Hirschsprung disease, we are talking about absence of ganglion within the neural plexus of the intestinal wall. This is a very different pathologies, so they are different terms. The Hirschsprung disease is an absence of ganglion cells within the neural plexus of the intestinal wall. It's more common in boys than girls. We boys take much for the girls, and the delayed passage of the meconium together with the distension of the abdomen in unusual clinical presentation, the plain abdominal X-ray will demonstrate dilated bowel loop with fluid level, and the barium enema can be helpful when it demonstrates the cone. And by the way, this cone is the defected part, while the dilated ganglionic proximal colon is the normal part, unlike the atresia of the cardia, where the dilatation of the esophagus is denoting this is a pathological part, while in Hirschsprung disease you will find that the contracted cone shape is the defective part. While in meconium ileus, you will find that the problem within the distal small bowel obstruction, secondary to the abnormal bulky and viscid meconium, and 90% of those infants will have cystic fibrosis. So you will do sweat chloride test or chloride sweat test. And abnormal meconium is a result of deficient intestinal secretion. This condition present during the first day of life with gross abnormal distension and bilious vomiting. And the X-ray will show distending coils of the bowel and typical mottled ground glass appearance. Fluid levels are scarce, and the meconium is viscid, so take care. Hirschsprung, about the ganglion meconium ileus, it's about the bulky viscid meconium. Every child we see touching our heart, so let's touch our congenital heart diseases, the diseases that can affect our child, and let's put our hand on it and exclude them together. Take care. The congenital heart diseases are divided into cyanotic and the non-cyanotic. The non-cyanotic are called acyanotic. Take care. The VSD is the most common cause for acyanotic heart disease, while the TGA is the most common at birth, while the Fallot is the most common overall for cyanotic heart disease. For surgeons, it's more important to be aware of the common congenital heart anomaly, because the main differentiation factor is whether the patient is cyanotic and acyanotic. Does the patient come bluish discoloration or not? And the key point to the question is that is it a tetralogy of Fallot is more common than the transposition of the great arteries, the TGE? Of course, the Fallot doesn't usually present until 2 months old, following the identification of the murmur or cyanosis. In the neonate, the transposition of the great arteries is the most common presentation causing cyanotic congenital heart disease. Take care. So to make it clear again, the Fallot is more common than the transposition of the great arteries. However, at birth, the transposition of the great arteries is the more common lesion, as a patient with Fallot generally presenting around 2 months old. This is regarding the cyanotic causes. And regarding the acyanotic causes, VSD is the more common than ASD in children. However, in adult, the ASD is more commonly to be diagnosed in adult. So in children, the acyanotic will be VSD. In adult, the ASD will be more common. And you have to be familiar with the causes of the acyanotic causes heart disease, like the VSD, ASD, beta ductus arteriosus, coarctation of the aorta, aortic valve stenosis, while the cyanotic, which will cause the patient to be cyanotic, is the tetralogy of Fallot, the transposition of the great arterioles, and we agree that at birth the transposition of great arterioles is more common than tetralogy of Fallot, because tetralogy of Fallot is the most common of them all, but it presents within 2-month-old, and the tricuspid atresia as well as the pulmonary valve stenosis. Take care. There is great surgeon. Take care from a very common trick in the exam. He will tell you a vague scenario about an 8-month-old baby with hemophilia presenting with intermittent episodes of crying and vomiting. So this is annoying baby. And the parents say the baby's stool is mixed with blood. On examination, there is a mass palpable over the right side of the abdomen. He is guiding you to puzzle your mind. Who is this annoying baby who is crying at age of 8 months? Take care, he didn't tell you red currant jelly stool. He told you there is a stool mixed with blood. In real life, the mother will not come to you, dear doctor, there is a sausage mass can be filled on the abdomen, and take care, this stool is red currant jelly stool. No, she will tell you there is a blood mixed stool. And you will examine the patient and you will find there is a mass within the right side of the abdomen. This is intussusception. Welcome to real life and welcome to MRCS exam. So take care. The intussusception is caused by invagination of segment of the bowel into an adjoining lower segment. It's either ileoileal or ileocolic. It's more common in boys. We boys take many diseases for the girls to make the girls safe, and usually occurs under 1 year old. Take care. Intussusception is associated with hemophilia, like his Hennickson line berbera. Hennickson line berbera is very common to be associated with intussusception. In this scenario, it wasn't very vague. He told you already that he has hemophilia. So take care. Even hemangioma and GIT lymphomas are associated with intussusception. The clinical feature will include severely colic abdominal pain, causing intermittent, insoluble cries with the child drawing up his legs. He is in severe pain and vomiting. Or even he will tell you only there is a stool mixed with blood and there is a sausage-shaped mass or a swelling within the abdomen. This is intussusception. And take care. In between the attack, the infant will be a very good, healthy, normal, sweet, angelic baby. Take care. The next question regarding the intussusception that will come in the exam, it's about the type of intussusception. Is it ileoileal, where the small intestine within the small intestine, or it's ileocolic, where the small intestine within the large intestine? Take care. The ileocolic can be done with pneumatic decompression or hydrostatic decompression, while the ileoileal, unfortunately, it will require laparotomy. Take care. And by the way, if the ileocolic didn't respond to the pneumatic or the hydrostatic decompression, go for laparotomy. You have to save this patient bowel, time equal bowel. It will go gangrenous even. Take care. And by the way, in the ultrasound, it will show claw or target sign. Isn't medicine is such an amazing topic? But examinations of medicine are monsters. And guess what? We are the monsters of the monsters. We are the master slayers of any monsters. We are the storms of the storms. And keep in this mind and never forget it. These great surgeons, you have to be familiar with the non-inflamed appendicitis, the mecal diverticulum, the vitello-intestinal duct patency. The mecal diverticulum is very common in real life. Take care. It's about 2% of the population, 2 inch long and 2 feet from the ileocecal valve, and being kept in mind whenever you enter any abdomen and you find the appendix is normal, always seek for the mecal diverticulum and don't miss it. Otherwise, you're gonna explore this abdomen again, searching for the mecal diverticulum, and no one wants this reputation in his work that he has done the appendicitis twice. It's almost always done once. So do it once and for all and think for mecal diverticulum. It's a congenital abnormality resulting in incomplete operation of the vitello-intestinal duct, because normally in the fetus, there is attachment between the vitellointestinal duct and the yolk sac. This disappears at 6 weeks of gestation. This is a very common rectal question, by the way, and the tip is free in the majority of the cases. It's almost always associated with enterocytoma, where there is umbilical sinus and omphaloileal fistula. Take care. And the arterial supply is the omphalomesenteric artery. It's found in about 2% of the population, 2 inch long and 2 feet from the ileocecal valve, typically lined by ileal mucosa, but ectopic gastric mucosa or pancreatic mucosa can be present, with the risk of peptic ulceration and pancreatic anginal mucosa can occur as well. What is the clinical presentation? Of course, normal asymptomatic, unless there is appendicitis, inflammation, and you enter and voila, there is no appendicitis, there is no inflammation in the appendix. Search for the Mickels for God's sake. In female or male, go for it. The complications are the result of obstruction, and the complications are result of ectopic tissue or inflammation. This is the clinical presentation. Take care. Removal is required if narrow neck or symptomatic, and the options are between wedge excision or formal small bowel resection and re-anastomosis. Take care. It has the rule of 2, and this is a reasonable 2 because it's 2% of the population, 2 inch long. 2 inch means 5 centimeter. 2 feet from the ileocecal valve means only 60 centimeter. Your hand palm, if you take a measurement of your hand, it will be about roughly 20 centimeter. So it's about 3 hands or 2 feet. 2 feet, 6 centimeter, 3 hands equals 60 centimeter. And the 2 more common in male. Again, women have taken this disease instead of females. And of course, 2 tissue types are involved, which are the GIT. Take care. They are typically found 2 feet proximal to the ileocecal valve. Again. Vitellointestinal duct patency, rule of 2. Do you remember something about the rule of 10? Yes, the phaeochromocytoma, but we agreed it's about 90%, not 10%. Again. We all agree that the Intussusception will present you with red caramel stool and abdominal mass, but take care. A 4-year-old girl presenting with symptoms of right-sided loin pain, lethargy, and hematuria. On examination, she has pyrexia and had a large mass in the right upper quadrant. The most likely underlying diagnosis will be this is a nephroplastoma. In a child who's of this age, the symptom described is nephroplastoma. This is the most likely diagnosis. Take care. It's usually present within the very earliest 4 years of life. And take care. It may often present as a mass associated with hematuria. Pyrexia may occur in 50% of the cases, but it's not essential. And often metastasis can occur early to the lung. It's treated by nephrectomy, and younger children have better prognosis. So the earlier you diagnose, the better the prognosis. Less than 1 year of age will have 80% overall survival. If you want to differentiate the nephroplastoma from the symptoms with the fever and hematuria from pelvic abscess or perinephric abscess, in abscess there will be confined to the Geroda fascia in the first instance, and hence anterior extension would be unlikely. You now understand the importance of knowing the fascia of Geroda or fascia of Zuckerkandel, the fascia surrounding the kidney. And yes, it's away from the other fascias. Do you remember Denonville and Valdair? The Valdair is posterior to the rectum and the Denonville is anterior, and yes, Geroda is the fascia around the kidney, while the sepson is around the lung, and the buccal fascia around the penis, and you have all the fascia now surrounding your holy study life. Fascia, and you understand. Now you can understand well the application of the fascia. So in the exam, he can trick you with a very short scenario, telling you a 4-year-old baby with a solid right-sided mass. No other symptom he is telling you about. Think of Walnut tumor, nephroplastoma. It's the commonest renal tumor in nephroplastoma, and the presentation commonly before 5-year-old of age, and 10% are bilateral, and presentation in 90% of the cases with a hard lateral abdominal mass, and 10% with fever and poor appetite, loss of weight, or even hematuria. Take care, take care, take care, take care. Someone asked me why it's not polycystic kidney disease. In polycystic kidney disease, he will give you another data, like ultrasound showing multiple cysts within both kidney and liver, and a patient that might have a perianeurysm. What could it be? It's infantile polycystic kidney. I agree with you, and it's autosomal recessive disease affecting the kidney and the liver. And he is a lucky patient with a lucky father and mother who are having the recessive gene of the polycystic kidney. They brought him a present with this polycystic kidney disease, and the kidney enlargement will be bilateral. And of course, in the Walnut tumor, he will giving you enough data to guide you to Walnut tumor, like the 4-year-old baby who is having a solid right-sided mass, and he will exclude it that it's anterior, not posterior, because in posterior you will think more with a Girota, and if you found fever, you will think more with an perinephric abscess. But he will guide you and say to you hematuria. Take care. You are the master of the masters. You are a surgeon. You can beat it. Don't create your own monster. You can know any scenario.